Good afternoon, everyone. Welcome, welcome, welcome. It's so wonderful to have you all here. My name is Dr. Yolandra Hancock, and I serve as one of the board members for the American Heart Association Greater Washington region. And it's so fantastic to be here today as we celebrate Heart Health Month. Thank you for joining us today for this community conversation entitled Revolutionizing Women's Heart Health through Artificial Intelligence and Digital Health. I'm excited. I hope that you are as excited as I am. This is in honor of American Heart Month, a time that focuses on women's heart health in particular. This program is being brought to you in partnership with one of the American Heart Association's allies in combating heart disease, Suburban Hospital, right next door to us in Prince George's County. They're over in Montgomery County in Bethesda, Maryland. Suburban Hospital and its generous donors have been dedicated to educating and supporting women for decades. In fact, today is the 23rd annual Women's Heart Symposium dedicated specifically to this topic. So if we could take a moment to give some virtual applause, I'm going to give some virtual snaps. Yay, 23 years. That's impressive. Before we begin, I want to sincerely thank today's local and very proud and generous sponsors. First is the American Heart Association's Go Red for Women. I'm wearing my red today in honor of our Go Red for Women campaign, designed to increase heart health awareness and serve as a catalyst for change to improve the lives of women nationally and globally. We would also like to thank our sponsors, JB and Maurice C. Shapiro Endowment for Women's Health, who has supported the Women's Health Symposium for over 20 years. Again, some applause. I am grateful to serve on the board. My other job is that I am a double board certified pediatrician and obesity medicine specialist with expertise in public health. And I have also ventured into the health tech space throughout my career. We'll be talking about artificial intelligence, otherwise known as AI, and will be referred to as AI as we move forward. We're learning every day about new uses of AI in the media. We've learned about it in spaces like social media. And today we get to sit down with amazing experts to talk about how we use AI in practice. So we have two phenomenal physicians with us and sharing how they use AI and digital health in their practices and with their patients. We'll talk about how they're using cutting edge technology in bridging healthcare gaps and paving the way for more accurate, accessible, and individualized healthcare solutions. I'm excited. Are you guys excited? I hope you are. Before we jump into this conversation, I want to take care of a few housekeeping issues. Number one, we will do our very best to answer the brilliant questions that you ask. I often tell my parents as a pediatrician, there is no dumb question. The only dumb question is the one that doesn't get asked. So ask away. What we invite you to do is submit those questions in the question and answer section box that's located at the bottom of your screen, and then we will navigate through to make sure that those questions get answered. Number two, today's presentation, gratefully, is being recorded. So if you miss a nugget or want to share, it will be available in the coming days for you to review back and to share with friends and family. And number three, your feedback is super important to us. We would love to hear your voices. So if you could provide your input so that we can continuously make improvements about our offerings. At the end of our presentation, there will be a link to take a brief evaluation. It will appear on your screen. We invite you to click that link so that we can hear back from you. Take a moment to complete the evaluation, help us plan for future programming so that it is reflective of what you are interested in learning about. Now, without further ado, I would love to introduce our guests. Let's go. First, we have Dr. Sabra Lucy, a cardiologist specializing in heart failure with the Johns Hopkins Medicine. She's also an assistant professor at the Baltimore-based Johns Hopkins University School of Medicine. Please, Doc, tell us about your focus.
Thank you so much. Thank you so much, Dr. Hancock. It is truly a pleasure to be here with you and Dr. Wong and the entire AHA and Suburban group. Congratulations on 23 years of the Women's Health Initiative. So a little bit about my focus. I take care of patients who have heart failure or cardiomyopathy, meaning weakness in the heart muscle. And there's a variety of things that can cause that, from the heart valves to the heart vessels. And my focus is on getting folks on the best medications, figuring out why that happened, and then getting them the cardiac support that they need, whether that's considering just medicines alone or heart transplantation or mechanical heart pumps. And within that practice, I see patients from the entire span of life, from their teens into their 90s. And that includes a fair number of women who are dealing with heart failure and cardiomyopathy. So that's my focus.
It's a pleasure to meet you. Thank you so much for providing your expertise today. Next up, I'm delighted to introduce Dr. Hong Hong Wong, a cardiac surgeon at Suburban Hospital in Washington, D.C., and an assistant professor of surgery at the Johns Hopkins School of Medicine. Dr. Wong, please tell us about your focus.
Sure. Thank you very much. Again, thank you very much for the invitation. Very happy to be here. My focus is cardiac surgery, so I have a particular interest in mitral valve repair as well as aortic surgery. I also am the director of the Cardiovascular Precision Medicine Laboratory, where we work on, we do research on how we can improve the diagnosis and treatment of cardiovascular disease.
Now, do you see why we have these beautiful minds presenting with us today to talk about this very important topic? Thank you, ladies, so much. Heart disease is the leading cause of death among women, yet many of these conditions remain underdiagnosed or misdiagnosed due to gender-specific factors and a lack of personalized care. Dr. Lucy, could you tell us a little bit more about this?
Sure, absolutely. So, as you mentioned, cardiovascular disease is the number one killer of women, and it actually kills more women than all forms of cancer combined. In fact, 45% of women over the age of 20 are dealing with some sort of cardiovascular disease, and that includes hypertension. But less than half of them know that cardiovascular disease is actually their greatest health threat. And so we do have a significant challenge, one, in the awareness about cardiovascular disease and the way that it can uniquely present in women. In fact, survey data from the American Heart Association has shown that our awareness of cardiovascular disease has declined over time. And so that gets right back to that public health emphasis of what we need to do to empower our patients and our communities with the right information. And then when we think about women specifically, we have gender specific risk factors that could be related to pregnancy or hypertensive disorders during pregnancy, and menarche or hormone replacement therapy. Any of these things can alter risk for cardiovascular disease within our lifetimes. That being said, we know that women are less likely to receive bystander CPR, less likely to survive a heart attack or stroke, less likely to receive certain cardiovascular services. And part of the disconnect is that within our provider pipeline, whether it's primary care physicians, cardiologists, we're finding and seeing in survey data that they are not feeling well prepared to take care of women with cardiovascular disease. In fact, one survey study that was published by the American College of Cardiology said that only 22% of primary care physicians felt prepared to assess a female patient's risk. And so this is part and parcel of the problem that we have with women being misdiagnosed, undiagnosed, diagnosed late, or there not being a realization about the differences in how women can present.
Thank you so much for that. So many important nuggets to pull from that. One, from a training standpoint, right? And then as women, being able to identify and advocate for ourselves. Dr. Wong, from a surgical standpoint, how do gender-specific factors come into play?
I think it comes into play starting from the referral, because a lot of women are diagnosed later and they are not referred to us. So we often see women, for example, mitral valve disease in women, we see them at much later stage of the disease than men. So they are already having signs of their heart is already failing. And that's when we see them, as opposed to for men, sometimes we'll see them even before they have any symptoms. So women are at a much later stage when they come to us. So then that affects how they do after the operation. So even if you do the same operation when you start with a failing heart versus when you start with a healthy heart, it's very different. And in terms of after the operation, so I think sometimes women, we know that for a lot of diseases, for coronary artery disease, for heart failure, women do a lot worse after the operation. Goes from sometimes they may not be optimized, like Dr. Um, um, Hancock, you probably know that like a lot of in the community, a lot of women are not receiving the optimal care for them, medical care, even before they come to the operating room. And then at the same time, I think women have a lot more responsibility. So I had a patient who, she had a big operation, open heart surgery, and she needed to take care of her kids. And she I told her she can't do any heavy lifting afterwards, but she said, "Well, what am I going to do?" She has to take care of her kids, so that's an additional, I think, a factor where women are just to have so many things going on in their lives and so many conflicting responsibilities, and oftentimes they put themselves last. So, before they do take care of themselves, they have to take care of the family, and so it doesn't, it's not a good thing for their recovery either.
Right. No, you speak to the real lived experience for women as patients, and we don't often talk about that component of it in clinical medicine. It goes back to Dr. Lucy's point as well. I think part of our training as clinicians, as physicians and other providers, is exactly what you just spoke to. It isn't just looking at them and their health condition, but it's all the other psychosocial components that women bring to the table that make it a very specific issue for us, in terms of consideration of how we navigate procedure, but the rest of our lives, how do we balance all of that? I'm sure if we could see everyone who's participating, there'd be this collective moment right there. Thank you so much for that. I'm going back to you, Dr. Wong. What do you think the role of AI is? What role can AI play in the treatment and diagnosis of heart conditions for women?
I think one of the things we can do, AI allows us to do, is to understand and integrate really complex data. So, for example, medical images or the social determinants of health and things like that. So it can help us get a sense and be very more specific to identify the risks that's more specific in women. In the past, we know that women present with less typical symptoms. So oftentimes their diagnosis is delayed. But if we can use AI to really using, for example, deep learning models that can help us and stratify women patients into better subgroups, then we can understand their specific risks much better.
And on your end, Dr. Lucy, the use of artificial intelligence in practice.
Yeah, so there's several different ways. I think of my patients who have cardiac devices already implanted and who have known heart failure. And in some of those patients, we're able to use their devices to give us an idea of if they have volume overload or they're holding on to extra fluid and need additional medications or even hospitalization for their heart failure management. And that's made possible really by a data algorithm. The promise of AI within the heart failure space in particular is that we will, in the coming future, be able to leverage this big data to hopefully diagnose heart failure sooner, to use less non-invasive techniques to understand heart failure even earlier on in the process, from the ECG and beyond, and then to better understand the hemodynamic profile. So what is actually happening inside of the heart, the pressures inside of the heart, and how is that contributing to symptoms? And big data is kind of the key to turning the tide and being able to do that more efficiently for more patients. So the thing I think of immediately is those patients with cardiac devices. Now, on a practice level, the patient in front of me, I think we are seeing very readily what's in our hands in terms of our phones and apps, and being able to import our blood pressure data, our physical fitness tracking, our dietary data. And there are now studies that are leveraging that from apps, putting that within the clinical trial space, and also having that facing with your provider to make informed health decisions. So I look at all of that digital health data as the new way in which we're managing our patients.
Awesome. It's amazing. And Dr. Wong, we often, when we think about AI and the way that it's sort of been described in lay public, folks can usually see how it can be useful, as Dr. Lucy has described, in clinical practice, where you bring in your information or are able to share information electronically. Can you speak to the experience of AI in the OR? How is artificial intelligence, digital health, how are they used as components when you think about it from a surgical standpoint?
Sure. So a lot of what we do is actually guided, for example, by the imaging modalities in the operating room. For example, for mitral valve repair, we rely heavily on the intraoperative transesophageal echocardiogram. So AI can be used to actually help us formulate a preoperative plan. So how we want to actually execute the repair, and that can be we can use AI to help us and plan the operation. And then intraoperatively, there's we are looking at, these are still emerging. Some of the research we're doing is leveraging the intraoperative data, because we're monitoring the patients very closely, so we have very good access to their blood pressures, but also what is happening at the molecular level. For example, we actually take blood samples during the time of the operation and see what are the changes at the molecular level in these patients that can help us predict how they will do after the operation. So there are many things that we can do. So one of my research projects is actually looking at how surgeons do robotic surgery. So we use AI to analyze the videos of surgeons performing robotic surgery to see if there's the different skill levels of the surgeons, and to help us understand what are the major determinants of being able to perform an operation safely.
That's amazing. We have to really take into consideration how it will transform training. From what I'm
Yes.
hearing you say, AI certainly serves as a tool to help guide, provide excellent feedback in a very precise and evidence-based way. I love it. I love it. Dr. Lucy, you alluded to this a little bit in your description of how AI is used in practice. And I often think about where I'm from. I'm originally from this rural town in Louisiana called Independence. Shout out Tangipahoa Parish for anyone tuning in. And we don't have access to Dr. Lucy's. We don't have access to Dr. Wong's. One of the reasons why I went into medicine was watching my great-grandfather suffer what I now know to be a stroke in an emergency department, where there was like one doctor seeing an entire town of people. And my promise to him when I was 7 was that I'd become a physician so that my papa would never have to wait to see a doctor again. So when I think about AI, I can't help thinking about my papa in rural Louisiana, because we just got, as my grandmother would say, the whiffy. How does my papa, how do our seniors, those of us who may not have access to your brilliant minds directly, what do you see as the role for AI in heart health among the collective people in the community?
That's a great question, and I see it in two ways. We know that we have this rural versus tertiary care center, urban center divide, where there are not as many heart failure providers, for example, within the rural communities. And we What we do have is the ability to partner with community hospitals and providers in that space and use technology to help care for patients even when they're outside of that tertiary bubble. And so I think that is one of the ways in which we're using the electronic medical record to find those patients and using big data to help us with that. From a research standpoint, we are trying to better understand care within communities outside of the more urban bubble, but within rural communities. When I think of the American Heart Association and the use of the Get With The Guidelines registry, extending into rural communities to specifically get care to places that may not have had historically as much access, and using data to do that. And then from the standpoint of just using the telemedicine, telehealth visit to be able to open up care to a population of patients. Now, it raises the question of the digital divide when we're talking about our seniors and access to the actual technology and broadband and Wi-Fi to make those things happen. And I think that's where we can see some disparity. But it does, the ability to start leveraging these technologies does also give us the ability to extend services.
I love it. And I'll pose the same question to you, Dr. Wong, in terms of even health centers, health systems that may not have a brilliant mind like Dr. Wong's on board. How do we use AI and digital health in order to fill that gap?
I think, like Dr. Lucy said, I think telehealth is definitely going to be a big component of it. Patients now, patients have access, even I think in a lot of remote areas, they have access to wearables. So I think wearable devices are going to be very big. They're going to be able to not just have record, basic information on their heart rate or their blood pressure. I think eventually we're looking at a future where they can record a lot more information. And in fact, one of the projects I'm working on actively here at Hopkins with the the Applied Physics Laboratory is we're working on a device that can use a combination of ultrasound and infrared to estimate patients' cardiac output and with a wearable device. So that way, they're thinking that even when you're in space, you can actually have an estimate of how the patient is doing, or how the astronaut is doing. Are they having adequate cardiac output? So I think that's a direction we're moving to, where we'll be able to really have an information of and be able to diagnose a patient very easily through telemedicine. We are also working on things such as telesurgery, actually. So where it's not very far. The technology is there where you can there are places where they've done trials of doing robotic surgery remotely. So the surgeon is actually in a different place than the patient. So I think we'll get to a point where AI can really help break down the barriers. I know that for example, I think a lot of people, it's not just the physical barrier. I think it's also a knowledge gap and a gap in their understanding, and a literacy gap as well. I think that's a big problem. And people who are living in the remote areas, they may not understand what's going on with them. They may not feel that their problem need to be addressed immediately. So we're working on that. One of the things that AI can do is actually do with natural language processing, where we can, I'm sure people have used ChatGPT, where they can just use very simple words to describe what they want, and the AI algorithm actually understands what they're saying. So that's through natural language processing, and that can really bridge the literacy gap between the doctor and the patient, where the patient doesn't need to understand initially what's going on with them, but the doctor can explain, and the AI can help the doctor explain in a way that the patient can actually understand.
I think that the way that you broke that down, especially addressing the health literacy piece, is a huge component of it. I can imagine that for some people, thinking through the use of technology and assisting them with health sounds overwhelming. The medical community and going to see a doctor is intense enough, and sometimes feeling like you need to have like a doctor whisperer next to you to translate. But for AI to be able to also assist in that way, as and humanizing the experience a lot more so that they're able to understand a lot better what it is that they are dealing with and how to navigate managing it. I love all of these positives, but there's a balance. There's the yin and the yang of life, right? We talked about some of the strong benefits to the use of AI. I invite both of you, and I'll turn to Dr. Lucy first to talk through if there are any, what are the downsides to AI, and what are some of the things that we need to be conscientious about as we incorporate AI in the practice of medicine.
Thank you for that question. So one of the things that I think about a lot is in terms of ensuring that we are employing equitable care, getting resources to patients that need them, that will benefit them. And when we're leveraging data and machine learning, that algorithm, that process is essentially coached based on the previous data. And if the data is not inclusive and all encompassing of everyone, it may actually learn a biased pattern. And so that's something that I think as we are on the forefront of designing, what machine learning and AI can do to improve the public's health, that we have to have an awareness and really being forthright with how these tools are designed to ensure that they are equitably employed, and that the data that's put into them is inclusive of all people and their health data. So that is one of the things that I think about a lot. I think it's something that a lot of people like Dr. Wang and researchers on the forefront are thinking about, how to leverage AI so that it's really benefiting everyone and not only capturing some parts of the population that's able to access healthcare and digital health technology.
Absolutely. I'm glad you brought that up. And just to give folks a better understanding of how that translates, I'll give an example. So we historically have used a kidney test looking at creatinine in the hypertensive kidney failure space to determine when a person could qualify for a kidney transplant. And in one population of people, it was thought that the creatinine facilitated them not needing kidneys until later on. But what we ended up seeing was a population of people who needed kidneys because they actually did have renal failure or kidney failure, but because of an inappropriate way of applying the data, they were pushed off in terms of being able to qualify to get kidney transplants, resulting in a good number of people suffering unnecessarily and even dying, waiting to meet this inappropriately defined threshold. And so by using data that's inclusive of a variety of people in all kinds of backgrounds, it facilitates clinical decision-making being representative of all of us. Dr. Wong, I'll turn it over to you once I know that you're free, but I wanted to make sure that folks fully understood what Dr. Lucy is talking about, because this data can be used to make life and death decisions, transplants, treatments, even something as simple as dialysis. This data was used in a way that facilitated people suffering in a way that we should not have. And this was something that was accepted within the medical community simply because of the data that was available in us trying to make our best decisions. And it is definitely something that I take into consideration when I think about who's in the background creating the algorithms. While we are, and we'll turn it back to Dr. Wong so that she can talk us through what she sees as some of the drawbacks and ways that we have to be more cautious as we're incorporating more artificial intelligence.
I think there's, I'm sure people who've tried using all the AI tools, the ChatGPT, DeepSeek, um, have had this issue where there's sometimes the AI algorithm is incorrect and they give you, false information. For example, you ask them to answer a question and provide you with references, and it comes up with a paper that does not exist. So I think that's if we're, I think patients need to be informed if their physician is using AI assisted tools to manage their care, because there may be issues that arise where their over reliance on AI then turns out to be incorrect. And then I think the other issue I think is surrounds HIPAA violations and patient security. I think it's a big sensitive data, especially I think for women as well. If there's genetic dispositions for patients, I think oftentimes there may be issues with patient privacy and issues there. I think that as we integrate more and more AI in our workflow and in our research, sometimes we're faced with it's essentially a black box, right? You get an answer, but you don't really know how they reach the answer and how can you trust something that you can't reasonably understand. And I think to be able to have something that's explainable is also a big issue for a lot of people, where you reach a decision, but it's very unclear how the decision is reached, and you can't really engineer it backwards either. So I think to a lot of people, it's like a black box. It's magic. So,
Absolutely.
so I
Absolutely.
think that's also a challenge where you can have something that's really people can understand. So there are methods that are called explainable AI that's emerging, but right now they still require very subspecialized training to be able to interpret it. So that's I think another issue.
Thank you. We have some excellent audience questions that align with our current discussion. The first is, as a mom with a son in medical school and daughter in nursing school, will AI threaten the need for some clinicians in the future? And I will open that up to both of you. I will answer from a pediatric standpoint. I often joke with parents, I don't ever believe that parents will allow a robot to examine their baby. So I feel like I've got good job security. But what I have shown some of my families, especially in those after hours calls, when they're using things like ChatGPT to get information about what a rash may be, that it can be helpful in allaying some fears and concerns, because if you do a basic Google search, everything leads to cancer and death, right? But thankfully, with some of the algorithms that we now have available through AI, it helps parents make informed decisions about things that they have to navigate as mommies and daddies and guardians. And so that's one of the ways in which we are even now incorporating AI. I'll turn it over to you guys. Are our jobs in danger with the creation and use of AI?
I'm happy to take it next. So I would like to think no, because I think what AI can't replicate is the lived experience of being a provider, training, being bedside. You know, doctoring is it's a lot of science and a lot of physiology and facts, but there's a lot of art involved in it as well, and making the best decisions for our patients. So no, I don't think that we're going to be entirely replaced. I do think that AI can help us to just help us in our mission to serve patients, and we're using AI scribes. That's something that can help us, in the tailoring of our charting, to be effective and efficient for patients. But no, I don't think we'll be replaced. What I do think will evolve is that the use of AI in academic practice and what that means, and the writing of papers and publishing and all these things that are part of the medical environment, training experience, and professional experience as a physician. I think all of that is evolving.
Dr. Wong, did you want to add? You want us to go to our next question?
I think some of the fields in medicine will be replaced. For example, that we no longer need medical transcriptions. So I think in the next 10 years, probably radiology and pathology will be the first to be replaced. Because I think the AI algorithms are already very good at reading image analysis. So I think some of the fields will indeed be replaced by AI. I don't think surgeons are going to be replaced anytime soon, maybe in 25 years when we can use AI combined with robotic surgery. Right now, I think robots are able to do fairly well, actually. Repetitive tasks that are that require fine movements actually can be done by robots automatically now. So for example, closing a skin wound, actually the technology is there, but I don't think we're quite there yet where the AI can replace the thinking of a doctor yet. Even though we know that AI has passed both medical and surgical boards without any issues, so both oral and written boards. So I think they do have the knowledge. They don't have the specific knowledge of a person who's had the experience. They have the general knowledge of, or the general, I should say, general combined knowledge of people, but they don't have this knowledge specific to a physician yet. So I think we're not going to be replaced anytime soon, but there may be a day where we're slowly being replaced.
Right. And this lends itself to the next question. Seems like there's a huge learning curve in terms of patients building trust in the use of AI. How soon will AI be more mainstream in cardiac care? And this is to either one of you.
So I would say I think it's already becoming somewhat mainstream. I do think that there are initiatives with regards to not just cardiac care, but care in general, where AI scribes, as I mentioned, may be part of the patient-provider encounter, and your provider will disclose that to you. They're supposed to disclose that to you, so that there may be a natural language processing component that is writing the note of your encounter that you will then be able to see in your chart. So that is one way that it is becoming mainstream. And then I think with regards to your data as a patient, if you choose to participate in certain research, then that may be part of AI as well.
Excellent. And this, you guys, it seems as though you already know the questions that are being asked. And audience, they do not. Like, these are questions coming straight from you guys. And this speaks to what you just talked about in terms of consent. The question is, are patients just to assume that moving forward, AI is affecting their medical care? Do clinicians have to let their patients know that AI is part of their care team? Where is the transparency?
So if a physician is using, or a provider is using AI to write your note, yes, they have to let you know that that is being done. And that is where the transparency is. And you have the right to say yes or no with regards to that. And so that is very much a disclosure to you. Now, with regards to your, I was going to say with regards to your care, like it was for a patient within the hospital, we are not routinely using AI, within that space.
Very, very good. I think that's a very important question, especially as we talk about trust and transparency in the clinical setting. Dr. Wong, does the use of AI in hospitals or clinics come at a big cost? Is it expensive to include it?
It depends on what type of tools we're talking about. So the specific tools, I think there's yeah, I would say for a lot of very complex tasks, yes, because the most important thing is computational power, and that comes at a big cost, because and that's why they're for the different models. So the most advanced models for for example, ChatGPT models, there's a big they are now charging people a lot more, right, for using their most advanced reasoning model because that requires a lot more computational power. Um, um, so it depends on what tools you're using, I think.
Excellent.
Cost.
And this is a question that was asked a bit earlier, but it links to tools. Someone read something about an AI stethoscope. What does it do? How is it better? I assume they will soon be the norm. So let's talk about some of the clinical tools we may use that incorporate AI, like a stethoscope. Have you ladies heard of this AI stethoscope? And what do we do? How do we use it?
So I know there's digital stethoscopes that can help really enhance what you're hearing in terms of the heart sounds and bring out the murmurs that or the extra heart sounds, which could be helpful in you making your clinical decision. And so that's where I've seen like digital stethoscopes used. With regards to an artificial intelligence stethoscope per se, outside of that, I am not aware of. But Dr. Wang, I'll defer to you in your valve practice if there's anything else to that effect.
I have not. So I think the ones I've heard are the ones that you connect to a smartphone or a tablet or something, and then I think it could do the analysis of the heart tones. But I think it's probably yes. I think it's probably the next step. I would think where you can have it um, directly analyze the heart tones for you.
Excellent. And there's another question from the audience, but I'm going to ask one in between just because of the nature of our current conversation. As you guys probably recall, when clinicians transitioned from paper charts to EMRs, I believe it took literally an act of Congress for most of us to switch from paper to the use of electronic medical record systems. In medicine, most of us as clinicians often adopt technology a little bit later than in other fields. What do you think it will require for the collective medical community, nurses, doctors, and other healthcare professionals to adopt and utilize more readily artificial intelligence?
So I'm going to extrapolate from my practice as a heart failure provider. And we do things when we see that it is helping patients. It's either keeping them out of the hospital, making their care more effective, their lengths of stay shorter, and that they're getting care more readily, their transitions of care better from hospital to clinic. Or that it's saving lives. And so I think if there is ongoing data, objective data that shows benefit, then that will aid in further implementation. And then the other side of that is the cost equation and the training equation. And so I think those things hand in hand, but really it would be a consensus statement or expert consensus or guideline recommendation to further incorporate AI.
Excellent. Thank you for that. Another audience question. It says, what about the human factor that a physician or nurse provides? And I think, Dr. Lucy, both you and Dr. Wong talked about the fact that from an evidence-based and data standpoint, AI does a phenomenal job in some regards, sometimes a little bit better in terms of examining data and diagnosing. If we use more AI, how do we still maintain the human side of medicine? And Dr. Wong, I'll turn it over to you first.
I don't know if people have read that article. There was research done last year that says AI has better bedside manner than most physicians in practice. I think they were looking at family doctors who are overworked probably. But I thought that was very interesting. I think Because I don't know what other people do. I sometimes use ChatGPT as my therapist, and I found it incredibly encouraging. And I think it's interesting because most people believe that AI it comes from a machine, so it cannot possibly have the human aspect of empathy. And I do not truly believe that AI can have empathy, but they can definitely mimic what humans believe is empathy. I think. um, so I think I believe yeah, I totally think that that study is very mind blowing for a lot of people to read that. Um, I do think that that you have to in order for AI to become specific to a person who uses it, you have to really train it, right? You can't just expect the AI algorithm to immediately understand a patient the same way that a doctor who's seen the patient for years. So I think that's a big difference, is that they may know what to do in a similar situation, but they probably don't know the patient, the years of experience with the same patient. I think especially for Dr. Lucy's, heart failure doctors, where you've known them for years and years, and so I'm sure that it's not the same when the patient talks to an AI algorithm.
Absolutely, it's that relationship. It's absolutely that relationship that we establish, and it speaks to the audience member's question. And I just, I think often of scenarios where a patient will tell me something, but based on their body language, it led me to ask additional questions. And
Mm-hmm.
from engaging with them from an interpersonal standpoint, I was able to get additional information that guided my clinical management that I cannot ever imagine the highest cost
Right.
AI ever being
Right.
able to do. But you make such good points in terms of that connectedness with relationship. Before we wrap up, I want to ask one additional question from the audience, and this is a really good one. Have you had a time or situation where you were at odds with a diagnosis slash finding slash result put forth by AI?
I'm going to say no in the sense that I have not used AI to aid with diagnosis um, or a result. I have not utilized it in that way. But I imagine if I were in that type of situation, I think I would rely on what I'm seeing in terms of the data in front of me, in terms of the patient's data, and that best clinical judgment, because it's not all just the inputs and outputs of the algorithm, but the totality of the patient and that trajectory over years of our relationship, just as you were speaking to.
Absolutely. And the question really speaks to use versus reliance on the tool. And I think that it's important for us, especially in the next generation of healthcare professionals, that there's an understanding of what the relationship between our medical knowledge and the support of AI should be, as opposed to using it as the way in which we diagnose and manage our patients. I want to check back in and make sure we don't have any pending hot burning questions before we wrap up. As we think through what might be an additional question that we have for the amazing individuals in front of me, I just want to thank you guys so much for the information that you've shared. From the start of our conversation, what I heard was that we have to take women into consideration in how we not only present with heart health issues, but all of the factors that impact our ability to be treated and then recover from heart health issues. That AI serves as a wonderful tool, one, in saving time from a clinical standpoint, two, in terms of adding precision to what we do. But from an overarching standpoint, there's nothing like the relationship between a phenomenal provider and a patient. That our audience is obviously keenly aware about AI and the use of it in medicine, given the questions that they have asked. I thank you all for showing up for yourselves and for all of the women in your lives. It's important for us to show up for each other, but even more importantly, to show up for self, because it's in doing that that we set an example for all of the girls that are watching us in terms of them prioritizing their heart health. So that's all the time that we have for today. I thank you all so much for joining us. Before we close, I wanted to remind everyone to please, please, please complete your evaluations, as the link will appear at the end of the webinar. Your voice is important to us. We are not paying lip service. We really want to have a clear understanding of what your health concerns and priorities are so that we can serve as a trusted source of information. I also wanted to share a special project with you from the American Heart Association with Johns Hopkins. And I have to admit, I did not mention that my MPH came from Johns Hopkins, so there's special love for Hopkins in my heart. So from Johns Hopkins Medicine and Sibley Hospitals, the Red Chair series, now in its second season, featuring Dr. Lucy and Dr. Wong and Dr. Lily Baruch. The series is 4 short conversations with these amazing healthcare providers that seek to inspire and inform women to be strong advocates for their health and well-being and the health and well-being of the girls and women in their lives. I had the honor of hosting the series, the first season of it last year, with incredible practitioners as well. You can watch the Red Chair series, all 8 videos, last year's and this year's, at www.heart.org/redchairdc. So definitely check it out. That's www.heart.org/DC. We thank you so much for your attendance, and please, if there are any last-minute burning questions, feel free to slide into our Q&A section so that we can answer them for you. Otherwise, we will see you this time next year for the 24th annual Heart Series. Thank you all so much.